Good morning, everybody. A role change here. I am moderating the first session, which is understanding and addressing the intersection between intimate partner violence and HIV. I have three excellent speakers. I am introducing them. And please, we have decided that we would like to do all the three presentations and then take questions at the end, so that we have enough time to be able to take all the questions that are necessary. I hope that's okay with everybody. Okay, so the first speaker is a friend for a long time. We worked together in the WHO multi-country study. Her name is Charlotte Watts. She is head of the Social and Mathematical Epidemiology Group and founding director of Gender Violence and Health Center in the Department of Global Health and Development. That's a mouthful. Originally trained as a mathematician with further training in epidemiology, economics, and social sciences method. She has over 15 years experience of working in international HIV and violence research and brings a strong multidisciplinary perspective to the complex challenge of addressing HIV and violence against women. Charlotte has more than 120 publications in peer-reviewed journal and manages a large portfolio of research, including research director of DFID-funded Strive, that is Structured Drivers HIV Drivers Research Program Consortium, and the chair of the expert working group to assess the global burden of interpersonal violence. She was a co-research team member for the WHO multi-country study on women's health and domestic violence, and a senior researcher on the IMAGE violence prevention study in South Africa that we're currently hearing a lot about. She has served on expert consultations for UNAIDS, WHO, the World Bank, and UNICEF, and was a member of the coordinating committee for US Institute of Medicine on the contagion on violence, and has been on the Track C organizing committee for several international AIDS conferences. She's a member of the peer review board for the UK Economic and Social Research Council and has reviewed grants for National Institutes of Health, the UK MRC and South African MRC, CIMH, and the European Union. We actually co-supervise some students together. You forgot to put that there. Right, may I invite Charlotte Watts to start her presentation.
Thank you, Jessie, and sorry for that long introduction. It's kind of the text you put on grant proposals, but are really embarrassed when that stuff gets read out. So what I was asked to do today was to synthesize some of the evidence around what do we know about the links between violence against women and HIV. And what I'm going to focus on here is the epidemiological evidence, but actually the evidence comes from many sources. It comes from women's testimonies about how violence and gender inequality impacts on their lives and their ability to protect themselves from HIV. It comes from in-depth qualitative research. And I think actually the quantitative field of epidemiology has been fairly slow to catch up and say, well, what do we know from the quantitative evidence? But that's what I'm going to focus on now. Next slide, please. So just to contextualize the issue of violence against women, globally, 30% of ever partnered women will experience physical or sexual violence in their lifetime. This is a slide that comes from recent estimates that were produced and published in Science. And so the region that we're in now is heavily affected by partner violence. It's not alone in facing this issue. It's an issue that affects all corners of the globe. We see high levels around the world. It's not as if there's a particular culture that's protected from violence. And so it's an issue that's common here as well as being common in many other settings. Next slide, please. So when you ask the question, well, what do we know about the relationship between having experienced partner violence and HIV, I just wanted to flag up that actually it sounds a really simple question, but actually it's quite tricky to answer because women experience so many different forms of violence. So what are we talking about? Is it physical? Is it sexual? Is it both? People, when they first think about the relationship between violence and HIV, think it must be to do with forced sex. But actually what researchers have been doing is saying, well, let's look at the different types of exposures that women experience. And our Is it just for sex, or is it other things that might contribute to their HIV risk? And as Jessie was talking about, there's psychological abuse and so on. When we think about how do we look at the association with HIV, what's the outcome do we use? Do we look at biologically measured HIV infection, or do we also look at things like, can women negotiate condom use? Can women access HIV services? Can women access treatment? Can women enroll in PMTCT? What I'm going to present to you today is data on HIV infection, but that is one small piece of the overall question about when we're really thinking about what does partner violence mean for HIV and the effectiveness of the HIV response. And I'll try and reflect on that a bit at the end. The other issue that, for the epidemiologists in the room, when you're trying to do this kind of analysis, is given that women experience so many different forms of violence, and many of them are intersecting, if you're comparing somebody who've experienced violence with no violence and say, well, is the person who's experienced violence, are they more likely to be at increased HIV risk? What is the comparison? Is it women who haven't had any form of violence? Is it that they haven't had that particular, say, sexual violence, but they have had physical violence? So actually the analysis gets quite tricky. And actually when you look at the peer-reviewed papers, sometimes researchers aren't thinking through that aspect of the analysis very carefully. So there's quite a lot of sort of muddiness in the evidence base, which I think is to do with people, this being a relatively new field and people still trying to figure out how do they do rigorous analysis in this area. And then there's just the issue around the quality of the evidence and the different types of evidence that we can speak to. The qualitative evidence is incredibly powerful. It's been there for many years about what violence means for women. But we're also we've got a large body of evidence now from cross-sectional surveys, so the large population surveys like the demographic and health surveys that Jessie was speaking about. And increasingly, we're also seeing some evidence come from cohort studies. And what cohort studies allow us to do is to say, let's see if women who've experienced violence acquire new infections. So we can very much say that actually the cause preceded the effect. And so it gives us the strongest type of evidence. And so what I'm going to present to you today is the data from the cohort data, so the strongest form of epidemiological evidence, but actually the messages that come out from that cohort data really come out as well from cross-sectional analyses and case control analyses as well. But just to kind of try and not overwhelm you with data too much. So next slide, please. So in terms of the cohort data, there are three, I think, kind of very interesting longitudinal studies that from developing countries that have looked at what is there an evidence of a link between a woman or an adolescent girl having experienced violence and acquiring infection. So this slide shows the results from a paper by Rachel Dukes and colleagues at the MRC in South Africa that was published in The Lancet. And what she looked at is whether women, sorry, I'm trying to get the pointer to work. I can never do technology. Okay. Whether women who've experienced violence are more likely to acquire HIV. And because this number is bigger than 1, it shows that it's significantly at increased risk. So this is women who've experienced more than one act of physical or sexual violence. I've also put a circle around this one, which isn't women who've necessarily experienced violence, but are in a highly unequal relationship. And actually, we're seeing a similar strength of association. So although we're talking about partner violence, I don't want you to divorce partner violence from the bigger phenomena of gender inequality, because actually, when I think about partner violence, what it is it's an extreme manifestation of gender inequality. And this is what this data is telling us, that it's gender inequality, and embedded in that is partner violence that's increasing women's risk of HIV. Next slide, please. So if we move closer to where we are now, this is data coming from RECI that looked at this issue again. But what was interesting about this study, and I apologize for all of the data, it was a lot of numbers. But what this study looked at is, well, what is the risk of HIV if we look at exposures to different forms of partner violence? And so these are the different types of acts of violence. This is what the risk is compared to women who've not experienced violence, for women who've experienced violence in the past year and ever. So what we see here, just to sort of highlight that women who've experienced any form of violence have, there's an adjusted incidence risk ratio, so an increased odds of HIV infection amongst women who've experienced any form of violence ever. And what's interesting, if you do go and work through all these numbers, is that if we look at the sexual violence, there's a very high risk, but it's not only sexual violence. If we look at physical violence, which is this one here, we see a similar size. So what this data is telling us is it's not just sexual violence that seems to be important. Physical violence also seems to be important. Severe physical violence, we're seeing a bit of a dose-response relationship, so we're seeing a higher risk again, but also we're seeing increased risk with verbal violence. So it appears from this data that it's not just sexual violence that seems to increase risk. Next slide, please. These insights from RACI are really supported by global data that have looked at this issue as well. So what I've done here is pull out some of the headlines from a systematic review that was just published this year that looked at globally what do we know about the evidence between exposures to partner violence and HIV infection. And the slides I've showed here are for cohort studies, but similar findings come out from the other kinds of studies. So this top one is looking at studies that have looked at physical partner violence. So these lines are basically summaries of different studies. If this is one, this line down here, if the lines are to the right of one, it means that that study is showing that there's increased risk. This big heavy triangle is the summary of the combination of these studies. What does this tell us overall? And so what we're seeing is that there's a significant increased risk from physical violence. That's what the global data is telling us. These are the findings from looking at sexual partner violence. There are more studies, again, pointing to significant increased risk. And then the last one here is any type of violence. Sorry, something's happened with the formatting here. But it points to increased risk. Next slide, please. So we're seeing strongly from the evidence that it's not just sexual violence in relationships that seems to be increasing women's risk of HIV. So when we try and understand what is going on, this is kind of a summary of what we think might be happening. So if we think about sexual violence, yes, that is potentially associated with increased risk. You've got unprotected forced sex happening. You might have issues around trauma and lacerations that has the potential to increase HIV transmission. We also have gender power imbalance. So that violence and the fear of violence may reduce women's ability to negotiate sex, whether sex happens, whether they can use a condom, or whether they could in the future, the issues where they could also negotiate other preventive methods, such as microbicides or pre-exposure HIV prophylaxis. And then the other factor that's emerging from the research is that the perpetrators of violence might also be at greater risk of HIV than other men. And what we tend to see is evidence of a clustering of risk behaviors, so that the men who are violent are also more likely, we see from surveys, to have concurrent sexual partners or to have engaged in commercial sex. And so what we're seeing is the knock-on effect of that if the perpetrators of partner violence are also likely to have other risk behaviors, they're also more likely to be HIV infected, which then puts their partner at greater risk than women who are in non-violent relationships. I hope that's clear. Next slide, please. And so to just talk about the clustering of risk behaviors a little bit more, There's quite a big body of evidence now on this issue, showing that men who report perpetrating partner violence are also more likely to have concurrent sexual partners, to have an infection with STI, problematic use of alcohol, and what's interesting is to refuse to use a condom. And that goes to that essence of the controlling behavior that Jessie was speaking about. In the WHO multi-country study, we explored this issue a little, and what we saw there was that women who were living with violent men were more likely actually to have asked their partner to use a condom than other women. So they were very much feeling like they're at risk of HIV, but actually that partner was more likely to refuse, because a key element around the dynamic of partner violence is often that element of control. And so that's part of the sort of constellation of behaviors that we have to be thinking about if we're trying to actually address violence. And underlying this clustering of behaviors are issues around masculinity. It makes sense if you start to think about it that that there might be a clustering of these behaviors, that the kind of guy who sleeps around might also kind of feel that it's part of being a man to be, you know, assertive with his partner, to maybe use violence with his partner. And so it's that clustering around masculinity and expectations in the relationship is the sort of core essence probably of what we have to deal with issues around violence, but also that could actually deal more effectively with issues around multiple sexual partners, lack of condom use as well. So actually if we can get to the core of the essence in our programming, we could be more effective in both addressing HIV and violence against women. Next slide, please. I focused a lot on the evidence from partner violence because of the focus of this meeting, but when we're thinking about HIV and the face of the HIV epidemic in the region, we also need to be very aware of different vulnerable groups and subpopulations where violence is a really important issue. So if we think about adolescents, there's a lot of concern about the high rates of infection amongst adolescent girls. What the WHO multi-country study showed very strongly, and the demographic and health surveys are also showing, is actually that much early sex is forced. So, for example, from the study that Jessie did as part of the WHO multi-country study, more than 15% of women reported that their first sexual experience was forced. So if we're thinking about violence and the HIV response, we have to look at early sexual coercion. And actually, when we interrogated the WHO data further, the earlier first sex occurred, the more likely it was that it was forced. So if we're concerned about early sex, if we're concerned about early pregnancy, we have to be concerned about sexual coercion. The other thing that you see very strongly from surveys and qualitative work with sex workers, and my colleagues here from UVRI can speak to this much better than I can, is the multiple experiences of violence that sex workers may experience. And in that case, it's complex. They experience often partner violence, so sex workers who have steady partners might be very vulnerable to violence, but also might experience violence from clients, from pimps, both sexual violence, physical violence, and economic forms of abuse. There's also the huge issue for women who are HIV positive, who may or may not know their status, fearing experiences of violence or rejection if their status becomes known. And that's a major challenge for the HIV field. Next slide, please. Oh, sorry. So when we're thinking about violence and how it undermines the response, I would say we have to talk about gender inequality and violence and how it undermines the HIV response. And so to sort of summarize there is the pathway through coerced sex. There is another pathway through experiences of violence, which means that women might have difficulty negotiating condom use, which means that they're at increased risk of HIV infection. We also have an important pathway through how women fear the negative repercussions of their HIV status becoming known, which poses an important barrier to accessing HIV testing, which might reduce things like the uptake of PMTCT, which may lead to vertical transmission, and similarly has an important impact on our treatment pathway as well. that may mean that women have barriers to accessing care and treatment, which might mean there's delayed or reduced coverage of treatment services, which will lead to increased morbidity and death. Next slide. So in conclusion, I think there's 5 main messages, I think, from the evidence to date. First, that violence against women and gender inequality is something that's widespread. So when we're thinking about the response, this isn't a small thing that happens occasionally in women's lives. It's 1 in 3 women. It's 1 in 4 women. So when we're thinking about the response, the challenge is, what does that mean about the way we think about HIV programming? It means in every aspect of HIV program, we have to be thinking, yeah, a lot of early sex is forced. Yes, sex workers are experiencing violence. Yes, women are fearing violence or experiencing violence. That has to be mainstreamed into our thinking about the HIV response. The epidemiological evidence is starting to catch up with what women's groups have been telling us for a long time, that exposures to violence are associated with increased risk of HIV. And that evidence is telling us it's not just coerced sex, it's the bigger issue of gender inequality and physical and verbal abuse. I've pointed to the evidence from Cohort Studies, which is very much speaking about, does exposures to violence lead to increase new infections? But actually that link between violence and HIV is complex, and that was what I was trying to summarize in that messy diagram. That violence and HIV share common risk factors. So things like concepts of masculinity, high levels of alcohol use, poverty and women's economic dependence on men. Independently, they're risk factors both for violence and for HIV. And so actually, if we could deal with those and start engaging in programming at that level, we can have benefits both for violence and for HIV. But also we have that interconnection that exposures to violence and HIV, that exposures to violence does exacerbate HIV risk. But also we have that violence might be a consequence of HIV, so that women who find out their status might be highly vulnerable to abuse. And so that we mustn't lose sight of that complexity and the ways of sort of thinking about the relationship. Because of this, violence and the fear of violence is an important barrier to an effective and scaled-up HIV response. At the moment, with treatment as prevention, a lot of enthusiasm about can we treat our way out of the epidemic. What this data points to is even we know treatment is highly, highly effective. It has incredible potential, but that doesn't mean we can't engage with it. We need to engage with the structural issues. And indeed, as we get more successful at reaching the people who can access services, our attention has to then focus to how do we make interventions meaningful for vulnerable groups, for populations and for groups that are experiencing violence, because that's where our challenges still remain, and we need to bring service to those groups. And so in terms of intervention options, and I'm trying to do a segue here to somewhere, I think there are intervention opportunities both in terms of thinking about our core HIV prevention programming, and how do we make sure that they're more sensitive and better equipped to addressing gender inequality and violence? How do we help health providers feel comfortable talking about issues around sexual coercion, around women's fear of violence, and not be something that closes off a conversation but actually starts a new conversation? But also, how can we think about those service-based responses, and how can we complement that with structural interventions that really try and tackle the root causes of both the HIV epidemic and the violence against women epidemic in combination? So with that, I'm going to thank you for your attention and just point to, next slide, the Strive website. So if you'd like more information about some of the work that our team are doing and that this sort of synthesis reflects, if you just Google Strive, you'll find it, but we try and keep it quite updated with latest evidence and thinking around these forms of interventions. Thank you.
Very deservedly, I always enjoy listening to Charlotte do her presentations, and I think this is echoed by the claps that she received.